truly enjoyed being part of the Healthcare Council's quality division for the last several years. And today, I'm very excited to introduce to you all Ajay Gupta. He is a certified information systems security professional. He has his MBA, and he is the co-founder and CEO of HSR.health. Over nearly a 30-year career in cybersecurity and information technology, Ajay has seen organizations create true competitive advantage from successful management of security and technology initiatives. At the same time, healthcare is burdened, we all know it, with outdated technology infrastructure and efficiencies, which are often measured in human lives. And so Ajay decided to take his understanding of technology and implementation to disrupt this and innovate in healthcare. And so in launching HSR.health, he leverages the best of tech to transform American healthcare into a system that innovates healthcare delivery, achieving improved quality, which is what we are all about, lower cost, and health equity. Under Ajay's leadership, HSR.health pivoted to support COVID during the pandemic, and through it, learned a lot of lessons and developed insights into how health risks impact a broader market. The company discovered a means for predicting future health risk based on social and environmental determinants of health, and works with public health, government at all levels, and businesses to assess the impact of those risks on their organizations, on their assets, and also on populations that they serve. In addition to his work at HSR.health, Ajay chairs the Health Domain Work Group for Open Geospatial Consortium, which is a global standard setting body for all things geo. He also serves as the chairman of the board of directors for Holy Cross Health, a multi-hospital social safety net health system in Montgomery County, Maryland. He's the commissioner on a newly formed commission on nurse reimbursement, serves as the co-lead for the Healthcare Infrastructure Work Group of the UN Chartered Group on Earth Observation, GEO, Health Community of Practice, COP, and is a member of the College of Boards of Visitors for Wake Forest University. And if that is not enough, he, in his free time, is all things sports, and something we just learned today, he is quite the karaoke king and likes U2, Sting, George Michael, and Imagine Dragons. So if nobody has any questions, I think we can pivot immediately to some songs. So it's all based on what you guys have, if you have questions or not. Just joking. So we are pleased to have Ajay here. We actually heard him at the annual conference for the Healthcare Council. We were very impressed and asked him to join us for a Q&A. And so hopefully you have lots of questions. I know I do, and the rest of the planning team does. And so I'm going to turn it over to Ajay, and then Maria is going to help facilitate the discussion, especially if you type your questions into the chat. She can then ask them, and then we can have healthy discussion. So with that, welcome, Ajay.
Thank you. Thank you for that very kind introduction. And thank you for teasing the fact that the last half of this session will be open mic karaoke. I don't know if anybody knew that when you were registering, but that's what we've signed up for today. You do not have to pick a U2 song. But on a serious note, I do thank everyone for coming, because I'm sure everybody was deciding where to spend their hour, whether it's here or with Becker Healthcare CEO, CFO, a summit that's going on right now. I hope at the end of this hour, you'll think that you made the right choice, staying here versus going with Becker's. But the topic here is quality. And one thing that Dr. White mentioned in her introduction was that during COVID, we were able to do some work to help U.S. and foreign governments and other organizations address the pandemic. And there was a really great opportunity to understand the role of quality, because there was no time for any quality oversight at all. As you know, in an actual state of emergency, we just had to, and the people that worked with us, the organizations that worked with us, they just had to make a decision, had to deploy the decision. And, to some extent, it's like hope for the best, right? We do the very best we can to make the very most intelligent algorithms and have the best collection of data that we can curate. But at the end of the day, there was no time for quality work or safety work or oversight work. We just had to go to the field with that, right? And of course, we learned very quickly, as I'm sure all of you remember, and really did try to do the best we could. And I think that there are a lot of things to be learned from that experience and how we can do quality back home when we, need to have more time, when it's not a state of emergency. So what we're going to do, I think, Maria, with your help, is we're just going to kick this conversation off in terms of your questions with respect to the role that quality has that AI solutions have in healthcare quality and safety.
Thank you, Ajay. I think we'll kick off. We had spoken briefly last week. One question came in pretty early, and I think everyone here really has an interest in it, and that is how can we use or have you seen AI used to reduce the administrative burden with regards to regulatory requirements? And we had spoken about, how busy our days are as quality leaders and how much writing that we have to do, not only within the organization, but for regulatory agencies and, being bogged down with responses to third-party insurers, to regulatory agencies, to Joint Commission, to Department of Health. So I think that's uppermost on our leaders' minds, if you could touch upon that.
So it's a great place to start. And really, honestly, because we had that question as a leading question, I don't think I needed to make sort of an opening statement. Because here's what I would say the answer to that is. There are going to be, and if you Google today, and then again next week, and then again the following week, more and more technology-based solutions that claim to be able to reduce regulatory burden, that claim to be able to reduce documentation requirements. Some are going to be more advanced than others. Some are going to have some use cases and case studies. The problem is that every hospital, every health system, in fact, often divisions within hospitals have such different workflows that you will not be able to say that this solution that may very well have worked elsewhere will really work for you. So you kind of have to, we all have to kind of try these tools out on our own, if you will, do our own clinical trial to see if they work for us, see how they can work for us. So what I recommend is, if we're talking about one aspect of that work, Maria, as you mentioned, documentation, I would suggest take a document that you have written, that you're happy with, right? Then see how ChatGPT would write it. Not necessarily something that you're doing today, maybe something from last month, last year, whatever, something that's a settled matter. See how ChatGPT would write it and see what the delta is, what the gap is, and how could you potentially train ChatGPT or it's one of its competitors that you like better to write what you need to write, whether it's 100% or 80% reducing your time to going from scratch to a complete document to going from something that's close to a finalized document. That is the kind of work that we need for all of the AI solutions, whether it's documentation or medical diagnostics. We need to be able to see how are they going to work in our clinical workflows with our patients and our clinical teams. This is, in some ways, it's kind of sad because it suggests that the cost benefit for scale, which is, we know, high, right? That the larger system you are a part of, you can buy supplies for a larger quantity and you get a discount on a per unit basis. Right now, we may not see that scale discount when it comes to the deployment of AI-based solutions because our own processes are so different. And there's some of that difference is unnecessary, so maybe we get rid of it, but some of those differences are necessary. It's because of the change in differences in clinicians, the differences in patients, the differences in settings. So that is really the answer that I'm sure you don't want to hear, but that's the answer to the problem. We have to kind of figure it out on our own. We have to kind of help tech figure out how their solutions truly work for us.
Thank you, Ajay. That was, I think, a very comprehensive answer, and you made some really good points on that. I know in our previous conversation, we spoke about utilizing AI, which may even be going on right now in our organizations without our knowledge, such as translation services for patients and radiology interpretations, which has been in place for a long, long time. Patient education, videos and lectures, literature that's handed out. If you could speak to those
Yeah.
areas.
Yeah, so you know that this is the most religiously and ethnically diverse part of the country, right? We do have lots of people that speak lots of languages. We also have staff that speak lots of languages, right? So there's many members of our clinical team that speak lots of languages. So a lot of times that translation is just done on the fly because there's someone on the floor that speaks the same language as somebody, a patient that comes in, right? That's helpful in this regard. And obviously there are going to be times when they aren't. So Google Translate can work. In the absence of direct, two people know the same language, and in the absence of our medical translation services, Google Translate has been shown to be a good starting point for communication, right? Now, of course, it is not intended for healthcare communication, and it is not intended for any critical level of communication. It's better than nothing. Microsoft's competitive product has one advantage to the last time I looked at Google Translate, which of course, as I said, these guys change very quickly, so they may have this too. But Microsoft Translate, I think they call it Azure's translator, allows users to build their own libraries, to have custom code, custom lexicon, custom language, right? This is to accommodate for things like local syntax, right? We know it's very common that there's different kinds of Spanish in the world, Spanish, Mexican Spanish, El Salvadorian Spanish, etc. But even dialects within a country, within an American English-speaking country, we have different dialects. So the Microsoft Translator service tries to allow you to create your own libraries that address this, which then could conceptually be a stronger translation service. It needs to be tested. And given this diversity, you kind of have to do it yourself to train it on the way language is used in your institutions. Which, given that we know, I mean, here, I don't know, we may represent 10 different hospitals on this one call of people who are part of the same organization. We know that our patients are different, right? They have different insurance, they have different age, different employment, they live in different places, where sometimes that distinction, I know ANOVA is really across into another country from Adventist here in Maryland, right? We know these things are different about our populations, so to use these tools to their most effective end, we're going to have to invest our time and energy, not necessarily our money, but our time and energy in making them work just for us. But I do think that once that time and energy is spent, I do think at the end of it, we will be closer and closer to that universal translator capability.
Thank you. Jamie, I see that you had a question. Did you want to ask, or I'll read it?
I can certainly ask. Thank you so much.
Okay.
This is such an interesting conversation. I'm assuming that other hospitals are similar to us, where we are being very guarded with what AI we are allowing ourselves to use at the moment while we figure out, how it impacts on particularly patient care. And so we have a committee, we have a cybersecurity committee that vets out any AI use, or is supposed to. However, we have found numerous products that we already have contracts with add AI, and we don't necessarily know. And so we're kind of stuck in this kind of vortex of, we want to be innovative, we want to use these new and innovative tools, but we also want to be super careful and vigilant about our PHI, et cetera, and choices that we're making in healthcare. And I was just wondering what your thought was on, how do we split that line between trying to be innovative, but also needing to be very vigilant?
Yeah, I don't know that there is a comprehensive universal answer for that, because a lot of it depends on the institution's risk tolerance and their belief or their relationship with regulators, right? That will determine where any line needs to be drawn. There's also some case history that we can lean back on, right? We know that Google and others have made very large, very broad BAA relationships with health systems, Mayo Clinic, and again, many, many others, where they have just had a blanket agreement, right? That the tech firm has access to the health institutions' patient records for the purposes of developing solutions that aid patient care. Something very broad and general like that, it covers everything that may happen underneath, right? So that is a potential solution that is available, right? It may not truly meet the guidelines of protecting patient data, because once you sign something as broad as that, you really do not know when the tech firm will use that data again in the future, nor do they know. They may only later on in the evolution of their development of products learn of a new use of past patient data and then start to incorporate it. This is a challenge that is beyond, it's industry-wide, and it may not necessarily be solved by us. It may be solved by our legal counsels.
Thank you. So, Ajay, if I could piggyback a little bit on Jamie's question, and we touched upon this last week, specifically speaking about translation services, you work in an academic center where you have residents or just any employee. They're going to be, as you said, translation services may not be available. It may be something you have to do right away. Someone whips out their phone and starts using a translation service. So my concern was that could be across the board in a lot of different arenas in the hospital, a lot of different departments. What do you suggest for us to look for or to implement in order to have some sort of control over what's utilized in the organization, and
Right.
that we're aware of what's being utilized?
Yeah, okay, so the last part is easy to answer, right? I would suggest awareness you can accomplish by having anybody note that in the record anywhere, that this thing happened, this encounter happened, and one member used the publicly available, freely available cell phone app for translation. You can at least record that, anybody. Because the service you're talking about is now advertised globally by many big tech players. Apple says it on their ads, Google has been doing it. So you cannot stop it now. It is an expectation of anybody that has a smartphone, right? And the reality is it is being used everywhere, every day for people who are in a place where they don't speak the language that other people there speak. So controlling it in terms of not letting it happen, that's not going to happen. We're past that. You can do something about awareness, right? You can say anytime you see this happening, whether you're the clinician, the nurse, med tech, anybody, just make sure we get it noted that it happened. But you're not going to stop that anymore. Nor maybe should you, right? These are not perfect tools. They're not aiming for perfection, but they are much better than being misunderstood or being completely not understood.
So how do you recommend when we start to implement these things? What type of process would you recommend?
So if you're implementing a translation service, or if you're implementing any AI solution at all for which quality and safety wants to have a voice, honestly, how do you implement new things now, whether they're AI or not? I don't think you want to invent totally new processes. You want to adapt the processes you currently have, which work, right? The processes we have in our hospitals today may be inefficient, may be outdated, and all those things. But we know they work because we know sick and injured people come through our hospitals, get better, and do get discharged home to their families. So our current processes has got to be the starting point. How do you have our current processes in place? There are a couple of caveats. One big caveat is when we have human clinicians and human nurses, one way we measure that is by outcomes, right? And if there's a bad outcome, we do a number of things to see how that happened and correct. With AI, because we should have less trust in AI than clinical teams that are educated in institutions with faculty and staff that we can know, and we may have some visibility into them. We trust them. We may not trust AI the same way. They were not developed by medical people. They were developed by technologists. So we need to have not just outcomes-based assessments of patients or that may be touched by AI, but really at also diagnosis and during treatment. So for instance, there's a lot of medical AI solutions that say they can scan diagnostic radiology and identify things, whether it is heart-related, breast cancer, etc. We may need to audit those at diagnosis to see that there isn't bias, error, hallucination, etc. And somewhere during treatment, if of course treatment was warranted. That kind of auditing or that sort of replication of our current outcomes-based assessments will be necessary, at least in the short term, until we have the same level of confidence with an AI-based solution as we would with a physician who makes a diagnosis.
Thank you. Thank you. Great suggestions. We have a question from Anne. What kind of regulatory or legal risk is there for using AI and noting it in the record, but we don't control it or have contractual oversight of it?
Yeah, and that's a good question. Obviously, the answer is from our legal teams. I think what I'm saying is that this is a tool that will be used by people because they expect that. There's an expectation, and they have been trained, if you want to use that word, by the media, by advertisements, that if you're talking to somebody who doesn't know your language and vice versa, you can use this tool to start a conversation. It is advertised too broadly now, and it's ubiquitous, so it's going to happen. So our issue then needs to be like it is today. What else happened in that encounter? Was there a physical exam? Was that exam appropriate? Was that correctly administered? Was there a diagnosis? Was that diagnosis plausible, reasonable, was and correct expectation of patient care? What treatments ensued from that diagnosis, et cetera, right? Those things should remain untouched. They should cover the fact that some of the data that led to the diagnosis, the treatment, et cetera, came through a channel. It came through a channel. It wasn't necessarily received directly from the patient. It was received from the patient who used this tool, right? That's it. That's what we can do. We can do that. What follows from that legally is legal counsel has to figure it out. But from a health standpoint, we can address that just as we would today. What was the quality rating of that encounter?
You had mentioned previously about doing a proactive risk assessment of an AI system that may be incorporated. I would imagine you'd recommend, based on the last question, that legal be at the table, because as you said, the horse is out of the barn. We're not going to stop it. So now it's just a matter of how are we going to make sure there are guidelines in place for us to be able to document, say, in those instances where something's used on the fly.
Yeah, so there's two areas. This AI, the translation, the Google Translate that's on somebody's phone, that's sort of the patient bringing it in, right? That's really not too different than if the patient is a person, a young person or sick person who can't talk for themselves at the moment. So a caregiver is saying whatever needs to be said. That's not really that different from that use case. But when we are bringing AI in, whether it is transcription services for patient and physician encounter, whether it's medical diagnostics, medical AI for diagnostic radiology, when we're bringing it in, that's a completely different set of steps. There, yes, you do have to do risk assessments, quality assessments, legal assessments before it comes in. Obviously, if you're bringing in a tool or you're making a large acquisition, legal will be involved. That's part of that process, right? It'll be at the table. What if you're bringing in an AI solution to deploy for patient care or operational issues? There are things that need to be done in that process. Currently, if you're bringing in a brand new kind of MRI machine, you may test it out certain ways. You may leverage the experience of other hospitals in testing out the new system and all those things. But with new AI solutions, there we have to do something like a clinical trial at our own institution. You can certainly read any of the material that may be provided by the developer, but there the testing and deployment plan has to include How will we know that this is working? How will we know that we have the capacity to do an audit at diagnosis if we need to, or during treatment if that's relevant to the AI case? So in addition to outcomes, how will we know? Those questions need to be asked to the vendor, and if they don't have an answer directly, then the first step is to plot out the testing and implementation in a way that provides that answer. For example, we use a lot of alerts in a hospital. Alert when a patient is going down or has a problem, right? What is the alert when an AI system is issuing a diagnosis that does not align with standard of care? Does that exist? Has that been thought through? And is that diagnosis different because the AI is brilliant and has found a set of relationships that suggest this patient is or isn't in the condition that the standard of care would suggest? That kind of development needs to be part of our role in the deployment.
I also foresee in the course of some of the things that you've been sharing, which are great points, but I also foresee some challenges with regulatory agencies, say with the Department of Health or with Joint Commission, because they have regulatory requirements that say when you are using translational services that it be approved, it be vetted, it be not just anyone on anyone's phone or whatever. I would think that we're going to have to bring those regulatory bodies to the table as well, so that when we do these
I love
vettings.
regulatory bodies. So quick note about the Joint Commission, right? So it may have happened to anybody here because we all, in some level, share this kind of patient population. But they noted at our last, Joint Commission review that we didn't mark translation in certain instances, certain patient care instances. And looking into it, we saw, well, those patients are Spanish-speaking patients, and their nurses are Spanish-speaking nurses, native. There's no translation. Yes, the encounter wasn't in English. It was in their native Spanish. Why would we suggest that's a translation issue? So I don't know if we want to necessarily bring regulators to the table. I think they're probably going to come on their own. But here is where one of the reasons, Maria, this is one of the reasons I do not think we necessarily have to pay money for some of these deployments, right? Because if there's a regulatory issue with respect to the use of an AI, the developer should be bearing a large portion of that effort. Their system should be ready for regulatory review and approval. If it is not, if there's work left for us to do, we'll do it if we want the tool. But that should come out of their budget. It should come out of their cost, right? In that regard, I think that some of these deployments really do need to be true clinical trials where we're working in collaboration with the tech firm to ensure that the solution works, the solution has the right opportunities for oversight, and the opportunities for regulatory approval. That kind of work is important.
So when we're purchasing or looking into it or trialing it, that's something that we bring up at that time if we foresee any regulatory issues with compliance.
If we compare that to our pharmaceuticals, right? We don't buy pharmaceuticals within maybe some unique cases. We don't buy pharmaceuticals unless they've already been approved and on the formulary, right? We don't necessarily use medications that's not approved by the FDA, right? Why would we use an AI system that isn't approved by the appropriate regulatory oversight body? And if it isn't approved, they get to pay for it.
Jamie, I see you have another question in the chat box. Are you still with us?
Yes, and I don't want to derail this conversation because this is fascinating. I had a slightly different question that actually came up in one of our executive meetings this past week where this is, maybe it's Maryland specific, I don't know, but in Maryland, hospitals are not able to use AI technology for billing and coding type uses. However, the payers are allowed to use AI in their denial process. And so one of the things we were discussing earlier this week is that the denials have increased by 50% since 2019. And it's just I know you work in Maryland hospital systems. I didn't know if you had a take on that or any insight into what we should be doing about, I hate to use the word inequity, but it does feel like we're not playing on a level playing field. I'm not sure that using AI is the right thing necessarily, but it just seems like, especially for those of us in quality, there's something that we should be answering this with, and I don't know what it is. I thought maybe we could see if you had any thoughts.
Well, here, yes, we're all aware of this, right? I'm sure we all have a lot of thoughts. I'm sure there's a lot of us on the call that would love to sort of weigh in on an answer to this question. So if there are, please do jump in. I think I see the question itself, Jamie, as you asked it, and don't hesitate. This is inequity. This is inequity in healthcare mandated by regulators, right? So I'd say because the Supreme Court has thrown out the Chevron deference and the Chevron doctrine, we should now push back on regulators. Obviously, their decision is federal regulators, and some of these are state regulators, but the concept of pushing back on regulators is something that we should adopt holistically, right? With everything. And we need to lead the way in American industry because we're the most regulated industry. So we have a responsibility, if you will, to the country, which we know, right? Healthcare has a responsibility to all mankind. We should be pushing back on regulations when we find something wrong. This is one area where we're finding something wrong. And we need, what is the solution? Do we want insurers and payers not to use AI? Or do we want to also be allowed to use it? Whatever the solution is, we come to. And maybe the Healthcare Council can have a session on sort of creating a policy paper to send to these regulators on this. But we need to push back. We need to demand demand equity as we do. I mean, our hospitals are the vanguard in trying to achieve health equity, right? Here's an example of something that the regulators could change kind of overnight that would help us get closer to that. So that's my response. Happy to open that up because that's something that anybody might want to vent on a little bit.
That is a challenging issue. Jamie, if I could ask, when you said you had a 50% increase in the denials, how many of them have you been able to overturn? Is it just something that they're throwing through a software program that's spitting out because it doesn't understand some of the nuances in the EHR notes?
I think from what I understand, the 50% increase in denials is the final denial after it was challenged. So I think one of the notions that I've heard recently too is that the denials come so quickly that those in hospitals who aren't using AI to answer to it, you almost run out of time to address the denial before the cycle starts again. So it really does feel like one group has these powerful tools and another group has no tools. And so I was feverishly writing some of your points, and I love the fact that you said that healthcare is the vanguard of health equity, and so we should be the ones that are pushing for equity here. I really appreciate that.
I also like the idea of the white paper. We do have to take charge, and we do have to stand up for a lot of the challenges that we are facing because they're coming down the pike very quickly. And as you said, we're not fighting the fight with the same tools.
Yeah, one thing that I'd say, and again, the legal counsel should weigh in, but I'd say that if we took some of those denials that didn't get paid, right, and compare them to past cases that were paid for the same patient condition, same, similarities, high level of similarities, I'd say we should not just rebuild the insurer and say, look, just because you have AI doesn't mean patient care decisions change, right? We should bill them and charge interest on the loss. And like everybody else does, pain and suffering, charge them a surcharge for all of the extra effort that we had to do. Give them something and just take that to court, right? Take that to court publicly saying, instead of now $1 million in claims because of everything, we're charging you, we're suing you for $3.8 million. Give them some pain that they can respond to. And, maybe that will help us change the light.
Anne has put another question in. Realistically, what are the appropriate regulatory oversight and approval bodies for the various AI products and tools? Who beyond the creators is really qualified to judge them, such as CAD in radiology? Who is the right body to provide approval for the products? The ACR, the IT vendor, or the FDA?
So the FDA is the body, right? So the FDA, and in fact, the first medical technology device that was approved by the FDA is from our area. It's Welldox, Blue Star for diabetes, right? So we do have some local experience and expertise that can work with the FDA to approve technology-based devices for patient care, right? Whether it's AI or other things. It is the FDA that has jurisdiction, that needs to exert jurisdiction here. So of course that means that we have to now wait and see what happens with the changes to HHS regulatory bodies overall.
Yeah. Any other questions? Has anyone? Oh, go ahead, Jamie. Did you have your hand up?
I think I have more of a broader. I don't want to, again, I don't want to stop this conversation. I have a broader question. So Maria, if you were going to add more to this, I defer to you first.
Oh, no, I was going to ask if anyone had implemented some AI, some form of AI, and what challenges they're facing or what benefits have they earned. So go ahead, you could ask your question.
I was just going to ask, Ajay, you are somebody who has founded an organization and a company that looks at AI and helps healthcare. Many of us on this call don't really, aside from dipping our toe in the water, even understand all of the terminology. What is it that we haven't asked, or what is it that you think we should be asking as quality healthcare leaders about this topic? Like, what didn't we ask you that you think we should be talking about? I guess that was my question. Where should we be looking right now, just in the broader sense?
That's a great question. Yeah, there's probably always a question that should have been asked, couldn't be asked, didn't have time, all those types of things. But one thing is, AI itself as an industry is in a growth phase. Even the best minds in AI don't really know what it's doing, what it can do, what it will do in a few years. So finding a way to keep our skills and insights up to speed is simply going to be a challenge, right? Obviously you can take courses in higher education or certificate programs. That's good, but takes too long. Venues like this are very good to hear certain things, but we do need to find a way to keep up to speed with what AI can do. Here's another area where we can lean on our vendors, right? We can have our vendors tell us what they're working on. What are they doing? How are they, when they have a roadmap, which all vendors do, what technologies will allow them to achieve the milestones on their roadmap? Not to ask them for any sensitive information, just what's going to happen, what's going to change that's going to let you do these things in the future that you're not doing today. Those are potentially exciting ways to try to stay abreast of what AI is going to be able to bring in the future. Obviously, you could bring in a consultant to advise on a regular basis or an ad hoc basis on what is coming down the line. That's a possibility. And if anybody has a budget for that kind of thing, then having that is a good idea for a period of time. Just like we all have in-house and external counsel for legal issues because we know they're going to happen. Just like we all probably have in-house and outside lobbyists because we know we have to talk to government. We may need, for at least for this period of time where the growth of artificial intelligence in medical devices and medical care is rising, some kind of external expert that we can work with on a regular basis to advise us on future solutions, on what's happening in the industry. That may be something to consider.
Maria, just wanted to offer a question. AJ's comments just now began to get into this domain, but I just want to respond to some of the comments earlier, about filing suit or something like that. What we often hear is a reluctance for an entity, for a health system, for a region to be the first of anything, and I can't help but wonder, where are the state and the national associations in this regard? I think it's quite a bit or quite a stretch to think that there is equity among the various health systems, the healthcare organizations, to be able to step out on their own, when in essence there are associations and there are groups of organizations that undoubtedly are experiencing similar challenges. So where does this sit on the platform for an organization such as AHA, being in Maryland, MHA, really just being deliberate and strategic about establishing it as a priority?
Great question, Deborah. Thank you.
So I would say to that, if anybody who has a relationship with AHA or any other nationwide association, do jump in. But I'd say we asked them that, right? So at Holy Cross's last board retreat earlier this year in February, MHA president and AHA vice president spoke, right? So they came to talk to us, and they will for all of us. Hopkins' last board retreat, I believe the AHA president attended and spoke. So we should ask them that, and obviously the Healthcare Council is an entity like those, so we can ask internally here, is this the kind of thing that this entity wants to, if not have a position on, at least raise as a question that the industry needs to have a position on?
So, Ajay, I'll just jump in here just a second and thank you for this excellent discussion. But yeah, so we are a member of a Region 3 American Hospital Association group, which is made up of North Carolina representatives, Kentucky, DC, Maryland, Virginia, West Virginia, and Delaware. And we meet quarterly. And this is a hot topic with them. And the American Hospital Association is working, especially on, Jamie brought up denials. I mean, this and pre-authorization. I mean, this is a strategy that the insurance companies have implemented just to make more money. And if they deny long enough, then pretty soon everybody gives up, and there is no collection. And so the who's the winner? The insurance companies. And so the American Hospital Association is addressing this as we speak, because every health system, every region of the American Hospital Association is concerned about it. So, and of course, AI plays into all this. So, yeah, they have committees working on it. They have policy people working on it. They have legislative representatives that are addressing it. So, where it'll all come down to, I don't know. But at our annual meeting last April, there was a whole morning just on the denials of insurance companies and how to address that, and a lot of creative ideas, like you just suggested, Ajay. Hey, charge them interest when they don't pay. But getting that to happen, that's another trick. So I don't know if that helps or not, but that's yeah, just to let the group know that the American Hospital Association is very much engaged in this issue.
Thank you, Les, for that. That's it's good to know that it's hitting everybody's radar. Probably we should check in with NAHQ as well, the National Association of Healthcare Quality Leaders.
Yes, especially with their new alliance with the Joint Commission.
Exactly.
It's hot off the press.
from the regulatory perspective, it's
That's
probably a
right.
good topic. Yeah.
That's right.
Well, the other thing too is that what sort of gives me fear in the pit of my stomach is that cool new technology and neat things, we are dealing with people's lives, their healthcare, their personal information. And so how do we move forward wisely and deliberately in something that we need to, be in the game, but doing so understanding the impact of the actions we take. That's my concern.
Yeah. You're right, but that's every day for us though, right? That's every day. We're always thinking of the consequences in our actions. What if diagnosis is wrong? What if the test is misadministered? So it's not that fear in the pit of your stomach is not new. That's the fear that's always there. It's just now we are so comfortable with the things we've been doing for 100 years. We kind of have it down, right? I mean, it's good, and in a way it's sad to say a kid can break their arm. It's no big deal because we can fix it. We really know we can fix it, right? That kind of takes the onus away from, hey, are we doing everything in society to help kids not break their arm, right? But in this area, only because it's brand new, maybe not only, maybe there's another reason too, but it's brand new, so that fear remanifests it. Don't let that cripple you. Just think of what you're trying to do with the AI solution. It could be documentation. It could be reading medical films. It could be assessing amongst your patient populations who's at the highest risk of readmissions. These are things that we know how to do. We're looking for technology to try to give us a better way to do it. Try, experiment, move forward, as long as you have in place the things you would do if something goes wrong, right? If the bone is not healing, even though we did everything we expected to do or needed to do to heal it, then we're going to do something else, right? We're going to do more x-rays. We'll look at more things. We'll start over. We know what we'll do if planned and expected treatment doesn't work. Have that in place when you build or deploy AI solutions, and you can move forward with confidence.
I think, speaking for myself, I think it's not so much that it's new, because as you said, we were always dealing with something new, new modalities, new equipment. I think it's the speed with which it is hitting our industry, and it's hitting in not only patient care, but it's hitting in the billing. And all these different areas have an immediate impact on the organization. And I think that's where some of the fear is coming from. And the discomfort, the level of discomfort is the speed.
Exactly.
Yeah. Go ahead.
No, go ahead.
Yeah, the speed is a big problem. I think it's good to note that some of the bleeding edge development of new AI solutions has started to slow down, which is a welcome sign, right? I don't think the slowdown at the bleeding edge is because they are not able to develop new tools. I think they're waiting, truly waiting for industry to learn how to use existing tools. But I completely agree, absolutely agree, Maria, that ours is not really an industry where there's a first mover advantage. Let anybody else go first. Wait until somebody, like reports that are coming out of the Mayo Clinic and others on the efficacy of some of their AI-based diagnostic tools, right? Wait for them to come out, wait for them to be assessed, and then start to deploy them later in your own with your own patients. But then as you do that, even if you are very confident in the solution because of where it's been deployed, you kind of always start from scratch. Right. Start from scratch and say, look, I'm going to deploy it in my workflow, which is different from other people's, with my clinicians and clinical teams, which are different from other people's, and my patients, which are definitely different than other people's. So the product that works there may really not work here. We do know it, right? We know it in pharmaceuticals, that the pharmaceutical may have wide appeal, but it doesn't necessarily cover everybody. So we have a collection of medications that are used in different situations. The same should be true here with AI solutions, if not for the solutions overall, but certainly in how they're deployed and what their workflow is going to be here. That process is important. And one thing that should, Kristen, give you pause is that if we don't go through a workflow of AI solutions, should they become market leaders, we may be forced to adopt their workflow at some time in the future. We don't really want to do that.
No, no, I just, but to the point of the speed, I find, like just jumping in without understanding the process, without understanding the ramifications or the potential pitfalls, just making sure we do it deliberately, because once again, the impact of what our potential is so high in someone's, health and their life. So, being very mindful of that, to me, is what's important.
Yeah.
And along that vein, we have a great question from Cynthia. Do you have a recommendation on how to level the competencies among clinicians that are now given access to any AI tools?
That's a very good question, right? So there was a report, anybody may have seen it on the New York Times, I think today, yesterday, or very recently, that certain AI tools that they think that ChatGPT outperformed in diagnosis clinicians, even clinicians that used their own ChatGPT-like chatbots, like an AI, right? So even clinicians and AIs didn't outperform a pure AI. Now, I'm going to explain what happened there. It's relevant to Cynthia's question, but tomorrow there's going to be a study saying that New York Times study is fake and proving it. So it may very well be a fake finding. But what it points to is exactly that not just because you have access to a great AI tool does not mean that you know how to use it. Our clinicians have to be taught how to use it, right? Jokingly, I can say that a scalpel in the hands of a surgeon can do magic. And if I used it, I might be able to open a letter, right? That's exactly the same thing with AI tools. They are very powerful, they are very sophisticated, and they have a lot of features. Just like if we open up Microsoft Word, there's a million features, and none of us use more than 2%, 3%, just because that's not part of anybody's normal day-to-day use. So how we train clinicians is going to become a challenge in the future. Clinicians, of course, are people who already have a lot of training. They already have a lot of continuing education that's required of their degree, so their certifications and the licenses. So figuring out ways to give them more training is simply going to be a challenge. We would hope that at least some clinicians are true hobbyists and they kind of want to learn, so they spend their own time learning. We hope that that's the case and they can be champions for the department. I said a moment ago that you may want to consider bringing on an expert on some sort of regular basis to help with training of clinicians. That is going to be a challenge. I wish there was an easy solution. Now, I will say we should push a lot of this training requirement onto the developers. Just like in the old days, at least, and I think even today to some extent, pharmaceuticals will provide information on how to use their medications, right? What are the contraindicators? What are the indicated? Where to use it? All that. They do that, right? At their expense. So we kind of have to push on developers that you need to deploy the solution in our system. You have to make sure we really know how to use it correctly all the time in all the cases, including in the middle of the night, which is when most of the emergencies happen, right? That is just simply a way around it.
Well, we've come to the end, almost the end of our hour. We're starting to lose people. Is there any other question out there that someone really would like to ask before we sign off? Well, Ajay, I think the conversation was absolutely great. You raised a lot of good points. Probably scared a few of us a little bit.
Well,
I'm going to turn.
Well, let me look. All right. One positive note. Technology deploys itself to the public so that the public can test and figure out how to use it, right? Technologists know how to build tech. They don't know necessarily how it works in the field. So they deploy it, let people figure that for them. That means we have an opportunity to get these at no cost. I'm not saying it's easy, but I think we can negotiate with tech players, especially the big ones like Google and Microsoft that have, literally $1 trillion asset value, right? We can get them to deploy solutions, train us, explain how to use it, get it fit into the clinical workflows, all at their cost. Then, of course, the license fee after that accrue, but the deployment and implementation could potentially be for free. So that hopefully is a little bit of optimism that I can leave you with.
Well, thank you so much. I'm going to turn us back over to Jamie to close us out.
Thank you so much. Thank you, Maria, for your wonderful facilitating. And thank you, Ajay. This has been very, very enlightening. Great conversation, a lot of good back and forth, which is greatly appreciated. And then for all of you who are on this call, you'll get a survey when you log off. Please take a moment to fill it out. We really do appreciate everybody's feedback, and we use it to identify what else we want to talk about in our future events, and then also just look forward to any news and information about the calendar year 2025 healthcare quality events. More to come on that. And again, thank you all for joining, and thank you again to Ajay for this fantastic discussion.